Thank you, Dr. Martinez. I'm pleased to be here this afternoon. Our study reports on a successful model of care to African trials. Our study was conducted at Nashville General Hospital at Meharry, which is in Nashville, Tennessee, and is the result of a partnership grant, an NCI-funded partnership grant with the Vanderbilt-Ingram Cancer Center and Meharry Medical College. Meharry Medical College is a minority-serving institution, and Nashville General Hospital is the clinical facility for that medical college, as well as the city or public hospital in Nashville. Most of the patients seen at Nashville General Hospital are uninsured or underinsured and are considered a medically underserved population. In addition, about 55% of the patients are African American. What we found is that through a successful implementation of a model of care, that more than 2/3 of our patients that are eligible for clinical trial participation were enrolled in studies. Just a little bit of background information for you. We know that approximately 20% of adult cancer patients are medically eligible for participation in a cancer clinical trial. However, less than 3% of all adult cancer patients actually participate in cancer clinical trials. And accrual is even less for minority and medically underserved populations. Interestingly, though, some studies show that minority groups are just as willing as Caucasians to participate in cancer clinical trials, but are less likely to be invited to participate. And we also know that those who do participate in clinical trials are generally insured patients and of a higher socioeconomic status. So our hypothesis was that using a well-rounded model of care, that we could increase participation of minorities and medically underserved persons in our cancer program. That clinical trials office is located at Nashville General Hospital and has permanent staff, full-time permanent staff who belong to that facility. To start our care, we identify every patient who has a diagnosis of cancer and begin to review their care. We do that through screening of all of our pathology reports and any abnormal screening reports that indicate a possibility of cancer. Once patients are identified through that mechanism, we enter their information into a database and produce a report that is reviewed on a weekly basis by our research and clinical teams. What we do is we navigate our patients through our system. One of the biggest barriers to care for minority and medically underserved persons is becoming lost to follow-up within the system. The systems are often very complicated and confusing for patients, and it's easy for them to miss appointments and fall out of the system of care. So we track them very carefully using our nurse navigator and our research nurses to ensure that patients attend their appointments. If they have barriers to getting to those appointments, such as transportation or child care, we try to help assist them with that so that their care is not delayed. The patients are screened for cancer clinical trial eligibility. If we have a trial for their disease and stage of disease, we notify the physician who is planning for their care. In addition to letting that physician know that we have a clinical trial available, we develop a plan to overcome any obstacles that might be faced. So, for example, if we have a clinical trial that involves daily radiation, transportation for daily radiation may be problematic. We don't have a radiation facility at Meharry Medical College. We have to use the facility at Vanderbilt, which is several miles away. So patients sometimes have difficulties with the transportation. So we make sure that's addressed before we even present the clinical trial to the patient so that that does not become a barrier to their participation. And finally, that clinical trial option is offered during the initial treatment discussion with the patient. That is, the first time the physician sits down to discuss what the treatment options might be, the clinical trial is right there as one of the treatment options. Therefore, it's not an afterthought. It doesn't make the patient feel like, oh, by the way, we have something you might want to participate in. We think that that perpetuates that feeling that they're being experimented upon. In addition, they don't have to go elsewhere to participate in the cancer clinical trial. They're able to receive that care, to participate in that trial in the facility that they're used to going to, as well as with the staff and the medical care providers that they're used to working with. In summary, we believe our model of care is replicable to any community cancer program. And a couple of the key points are that the cancer clinical trials staff are permanent. They're fully integrated into our clinical program. That is, the research staff work hand in hand with the clinical care providers. Our approach is prospective. That is, we know up front if we have a trial that potentially this patient may participate in, and therefore it's offered up to them as another treatment option, not, as I said earlier, an afterthought. And finally, we have a lot of resources because patients who are seen in a public hospital frequently have many socioeconomic challenges. So we utilize our nurse navigator and our full research staff to help not only accrue patients to clinical trials, but also to retain them to the completion of that clinical trial. So thank you for your attention.